Welcome to my lecture on pharmacokinetics and just a general introduction to pharmacology. First, I'd like you to take a few minutes to think and decide how you would classify these drugs from one being the most dangerous, and we should restrict fully, to five, the least dangerous, and we should have no restrictions for alcohol, cocaine, cough syrup, ecstasy, heroin, LSD, cannabis, methamphetamine, nicotine, and Valium or Xanax. So before we come back to that, first I want to start with what is a drug? Well, at the basic level, a drug is a chemical. A phytochemical is simply a chemical from a plant. The traditional definition of a drug is any chemical that alters the physiology of the body. But one issue that this brings up is what about food and nutrients like cake or sugar itself? In fact, in another class of mine right now, we're debating what is more addictive, sugar or cocaine. But assuming that we exclude food and nutrients from our definition, then that would mean that any chemical that alters the physiology of a body other than food or nutrients is a drug. And this would have various intended uses like medicinal, intoxicating, or performance enhancing. There are still, caveats there, like many things with science. Like, for example, what about a drug like vitamin C? So, vitamin C, you could argue can be taken as a drug. Like if you take it as emergency, you could eat it as an orange as well. That would also be providing some nutrition for your body. But there's also this interesting caveat here that vitamin C actually has no evidence that it prevents or reduces the time of a common cold. In fact, that's primarily a myth that's still in place because of Linus Pauling, one of the few people who's won two Nobel Prizes, so a brilliant scientist, but he believed that vitamin C could cure cancer and the common cold. We sort of stopped saying the cure cancer part, although he did write a book on the matter. But we still have not let go of this idea that it cures the cold. So anyway, if you're taking vitamin C and you think that it cured your cold, is it a drug? It becomes complicated. And then caffeine, you can go down that rabbit hole too. I mean, there are lots of ways that we use caffeine as in nutritional compositions at the very least. So when is caffeine a drug versus a nutrient is something that could be debated. But in general, in this class, we're going to be talking about psychoactive drugs. So, does it pertain to effects on mood, thinking, and behavior? So, a psychoactive drug would be a drug that produces effects on mood, thinking, or behavior. And this is studied in the field of psychopharmacology or neuropharmacology, the scientific study of the effects of drugs on behavior, really a union of the fields of psychology and pharmacology. And I think of myself as more of a neuropsychopharmacologist. I specifically approach this from the perspective of the brain. But here are different ways that you could describe a drug. You can start with a chemical formula, the structural formula, which will help you think about this in terms of its 3D shape and how it might fit in as a key in a receptor hole. The generic name of this chemical, its trade name Marinol, meaning like what would it be marketed under as a trademark. At least that's how we do it in our country, in the United States. And then there are various slang names that tend to accompany one of these names as well. I tend to use the generic name, as do most psychopharmacologists. Drugs can be grouped together into classes that are based on some sort of shared attribute. Some examples are pharmacological mechanism of action, like a mu opioid receptor agonist, an SSRI, or an NMDA receptor. And you also have your chemical structures like barbiturates, therapeutic structure, or morphinin would be another chemical structure to a barbiturate. or morphine-like compounds like opioids. Then you have your therapeutic use. You could say that these drugs are analgesic. They all reduce pain. These drugs are all anxiolytic. They all reduce anxiety. They're all antidepressants. They're all hallucinogens. And then hallucinogens, could have very different, chemical structures. You have some that resemble serotonin, you have some that resemble dopamine, and then you have some that resemble neither, that active glutamate receptors. You can classify drugs based on their general behavioral effects. Are they stimulants? Are they hallucinogens? Are they depressants? And there are other things to consider too. You could say this is a club drug, this is an inhalant. Classifying drugs is complicated and is done a lot of different ways by a lot of different people. And some of these classifications make no sense. One of my favorites is narcotics. Narcotic means something that's supposed to make you sleepy or go to sleep. Yet legally, cocaine is a narcotic. It makes absolutely no sense, but it's just a legal classification. There are many psychoactive drugs and many drugs of abuse. Many are scheduled according to the 1970 Controlled Substances Act and subsequent modifications according to their potential for abuse, the likelihood for them to produce dependence, their accepted medicinal use in the United States, and accepted use in international treaties, which is where this gets really complicated and political. And really, I mean, things like the Opium Wars, for example, have shaped the world tremendously, and like how we, our drug treaties and some of these things that have resulted as a consequence have paved the way for fentanyl in America today, and really, quite frankly, international relations. Right. The Opium Wars, in particular, are one that I might look up if I have more time and are curious. But we schedule these drugs according to 5 schedules. Schedule 1 being the worst. These are drugs that we generally consider to have no medicinal value and have a high potential for abuse. Interestingly, I mean, like MDMA, there's very little, potential for abuse, relatively speaking. Cannabis, the dependence is relatively minor, sleep deprivation, irritability. Heroin, that might deserve a spot up there. LSD also, similar to MDMA, very little abuse liability. Then you get down to Schedule 2, where we say cocaine and methamphetamine are safer than cannabis. And, obviously this all sort of flies off the rails pretty quickly. Most of this was put together by senators in 1978, based off of previous like conflicts with other nations and our own racist policies. Cannabis in particular, was made Schedule 1 due to somebody by the name of Henry Anslinger. Anslinger was the first drug czar. Anslinger served many presidents, including JFK and Nixon. He was an advisor of drug policy. He was also a pretty racist person, and he wanted to associate cannabis, which at the time in America was called Indian hemp, because it was brought to Britain from the country of India, where it was first introduced as a medicine to the Western world, by Brooks O'Shaughnessy, who first brought it over as a medicine. And then it was brought as a tincture into the United States and sold in pharmacies as Indian hemp, or cannabis, then Anslinger decided to call it marijuana in the United States and really associate it with Mexican immigrants who we were coming out of the Great Depression, and there was, a lot of animosity toward immigrants and people just looking to blame their own woes on somebody else. So history repeats itself a lot in this way. So anyway, Anslinger really vilified cannabis and called it, marijuana, basically associated with Mexican immigrants, and created a lot of stigma about the drug that, didn't exist. There's a lot of yellow journalism at the time. Like a lot of these problems of today are really were there then as well. Just things to be aware of. Anyway, psychopharmacology studies drug effects, which are changes in a drug might produce on an animal's physiological processes and behavior. It is very important to note, and if I can remember, we'll use this exact wording on a test question. A drug does not like you do not have like a cocaine on your body. You have cocaine effects on your body. Cocaine produces many effects. Like it's not like cocaine is a thing that produces like a cocaine effect. Cocaine produces many effects by acting on physiological mechanisms that produce physiological outcomes and processes in your body already. Some of these might be good, some of these might be bad. It's not going to be just one effect. Cocaine, in fact, is a good example because it produces approach avoidance behaviors typically. An animal that is dependent on cocaine will run down a runway to get it and get to the end gate and then retreat because it has some bad elements too, right? I mean, that animal knows they're going to like anxiety is going to go up, other things are going to go up, but oh damn it, I really want it, and they're going to go get it anyway because to that animal, the pros effects outweigh the negative effects. But any drug is going to produce many effects because it's going to be acting on many mechanisms throughout the body. Because many of the chemicals and receptors that we have, proteins, are redundantly used throughout the body in various mechanisms. It's also important to think of the site of action. This is the location at which molecules of drugs interact with molecules located on or in cells of the body, affecting some biochemical processes of these cells. The concept of pharmacokinetics involves the movement of drugs throughout the body. This is an incredibly important concept to understand in terms of drugs of abuse. It is the primary thing that drug users will manipulate. It is the primary thing that medical doctors will manipulate when you come under their care. They will give you an IV line so they can control your bioavailability by manipulating pharmacokinetics and bypassing all this annoying stomach things and all these things that drug users will also find ways around because the metabolism and the drug going through the gastrointestinal tract first is going to take a lot of the drug out of the system. So, you find alternative ways to get the drug into you. But pharmacokinetics is a study of drug absorption, distribution within the body, its metabolism, and excretion over time. How will the drug get in? IV, going the IV route is going to produce a very different effect than taking it orally. Smoking it is going to be more similar to the IV route than taking it orally, for example. So these are things to consider. Where will it go once it gets in there? Is it going to go through the liver? Bypassing the liver is one thing that drug users tend to find a way to do. Will it stay in? How can it be reabsorbed? And during that process, is it turned into active metabolites that are going to produce their own effects in the body? And in some cases, you could even reintroduce because they would still be active in the urine. Absorption depends on the route of administration. An IV drug taken IV is going to produce very different effects than a drug taken orally. This can also influence drug distribution, or which here, how soluble a drug is and its ability to pass through membranes is also going to play a key role in how it's going to distribute. Some drugs also love fat. Cannabis is a great example of this. Cannabis is a lipid, and it loves other lipids. So if you have a lot of lipids in your body, cannabis will stick to them and slowly be excreted over weeks. So that slow excretion over weeks, could, sort of serve as its own methadone for cannabis, if you will. Like, it sort of comes with its own time release agonist therapy. After you get really high on cannabis, that will be there being released in small amounts for a period of weeks afterward. But in addition, that can also lead to a failed drug test. Other drugs like cocaine that don't love fat don't stick to it and are completely out of the system within a couple of days. Metabolism depends on the individual's variance in enzymes and transporters. But, there are enzymes in your liver that break down, drugs. Cytochrome P450 is the most common family. This is the chemical family that also breaks down alcohol. In certain international populations that do not tolerate alcohol well, there are genetic modifications to this enzyme leading to alcohol not being metabolized well. It can lead to people becoming very red, is one of the first signs you see if you are drinking alcohol with someone that has this genetic modification. It can be very dangerous for these people to continue drinking high amounts of alcohol. Well, really, it can be dangerous for anyone to continue drinking this poison in high amounts. Here is a picture from my Drugs, Brain, and Behavior textbook of all the steps of pharmacokinetics. This is from a more advanced class, and I'm certainly not going to ask you to draw this by any stretch of the imagination, but it helps, I think, walk through the process. You take in the drug, and here how you take it, whether it's orally or IV, is going to make a huge difference. And then it's going to be absorbed and moved around the body. And here, depending on if it loves fat or water, is going to make a tremendous difference, as will the makeup of your body. Are you big? Are you small? Where is this drug going to go in you? Will it bind to the target receptors, and where are those located? Or will it then bind to inactive storage sites like fat or bone? And then will it be excreted, and how will this occur? Is it going to go through the kidneys? Is it also going to be processed through the liver? Typically these things would go through the liver first before they're excreted. And during this process, other metabolites will be made. Some of these will be active metabolites that can then go on and produce their own effects in the body. And then depending on the pH of your urine relative to the pH of your blood, some of those active metabolites will be reabsorbed back into the blood. Some drug users will even save their urine and drink it to get these active metabolites. If it comes to that, it's possible there might be a problem, though. So something to look into. Routes of administration, are a great place to start. We have your enteral routes, which is a method of drug administration using the gastrointestinal tract, taking it orally. Or the parental route, the method of drug administration not using the GI tract. This would be snorting, smoking, IV use. IV use is really what drug users tend to graduate to, and medical doctors prefer, because it is one way to completely control bioavailability. You don't have to worry about the drug getting stuck in the fat. You don't need to be worried about the drug having to pass through flat membranes. You don't need to be worried about the drug being metabolized by the liver before it gets to the brain. Nope, it's just going to go straight there in whatever amount you put in that syringe. It's also very dangerous and deadly. The intraperitoneal route is a very common route in animal studies, in part because it's easy to get to without injecting in an organ. But the injections typically occur in the peritoneal cavity, the space surrounding the stomach and intestines and organs. It produces a rapid organ absorption, but nowhere near as fast as the IV route. And you also lose a lot of drug this way. So I would say, for example, if I had to guess that if I were to give 0.1 milligram of a drug to a rat IV, what same dose would I need to give to the animal to give it IP to get the same effect? I would say around 1 milligram, about an exponential increase in dose would be required. IM is similar to IP in terms of its pharmacokinetics. Here, this is something you see early in opioid abuse as well. Here the drug would have similar time course to IP or intraperitoneal route, just maybe a little slower onset and offset. Subcutaneous is going to be the slowest onset, and you're going to lose the most drug this way. Your maximal effect would go down a little bit. But here the injection would occur in the space right beneath the skin. This is only used in small volumes and very common for insulin. TB tests are also administered this way. At one point, when I worked in a monkey building or research lab, you had to do these things every month, and not the way you'd think it too. It was more so we wouldn't give they didn't want us to give TB to the monkeys. They were worth more. But the oral amount, also called abbreviated PO or per os, Latin for per mouth, is the slowest route. This is typically how we give medicines, outpatient medications in an outpatient setting, though, and least common in animal studies. You try to make an angry monkey take a bitter medicine. It just doesn't work very well. Some drugs also can't be administered orally due to their pH of the stomach. The pH of the stomach is highly acidic, and only certain drugs can be tolerated through that. Sublingual is another route of administration. This can occur by placing drug on or beneath the tongue. The drug is absorbed through capillaries that supply the mucous membrane of the mouth. You can tend to get higher blood content of, for example, cannabinoids by taking the sublingual tincture versus taking the brownie. Also not used in animal studies. Nitroglycerin would be administered in this way, can be administered in this way. Intrarectal is common at times, especially in children. Suppositories are common. I used to, in my drugs class, I include a video here from the Colbert Report, where, but now they've done it in movies too, where they parody this concept of butt chugging. This becomes common on college campuses from time to time with alcohol, but also in ways to administer other drugs of abuse. And the idea, and you can also do this vaginally, but the idea is that, if you take it rectally or vaginally, the drug would enter the capillaries of the rectum as long as you don't go too far up. If you go too far up, the drug can end up going into the hepatic portal vein and go straight to the liver, basically defeating the purpose of what you're trying to do here. But what you're trying to do is not to go too far up and get those capillaries of the rectum or vagina, so the drug will enter into the blood system after the portal vein and then go straight up to the brain. Topical, is an administration directly under the skin. This typically occurs in ointment, patches, creams, relatively slow and low maximal effect. Inhalation and slow can be good. I might say. Sometimes you want a long, slow bioavailability. Like for example, if you want just a little nicotine on board at all times to prevent those cigarette cravings, it could be very effective. Inhalation would be pretty rapid, probably your closest thing that you're going to get to snorting or IV route. Also, implants are becoming more common. In addition, tattoos. I think you're going to see more tattoos in terms of biosensors and also drugs as a way of administering something slowly over time. But these are long-acting forms of subcutaneous injections that can be deposited, and there are various ways that this is occurring. You can also have intracerebroventricular drug administrations. This is something we pretty much only do in the lab setting. Right. It allows you to measure how a drug has an effect in a specific area. So, for example, it allowed us to know that cocaine might act in this region to produce, like, because it's self-administered there. But if we have the animal injected into this brain region, it doesn't result in the animal pressing a lever to get it. Here's a general table that gets into how these routes of administration can influence where they're going, what barrier they're going through, and how quickly they act. Inhalation and IV are going to be fast. IM, subcutaneous, a little slower. Intraperitoneal should be in that area as well. Intranasal and sublingual, a little slower. Oral, very slow. Rectal, variable, can be faster. And you're certainly avoiding the first pass liver metabolism, depending on if it's done right. And then transdermal, very slow. This is the curve that I tend to like more. I could see myself putting this on a test and asking you to label it and maybe tell me a little bit about it. But the IV route is going to be fastest. You almost have no ascending limb of getting the concentration into the blood. It's just you start high and then you see a rapid decay. The max amount that you would get at a fixed amount administered would be much higher than any other route. When you give it IP or IM, that intraperitoneal is going to slow down a little, and then if you give it per os or orally, it will be much slower, and you're just going to get about a much lower amount actually entering the blood because it's going to go through the liver first. Again, there are many different drug delivery systems that have been developed and many more that are being developed, even including tattoos. Right. People have put LSD, on many different things. I do recall a student telling me a story in my drugs class once of selling acid at Red Rocks and having way too many doses absorbed in their sock, unwittingly, and that turning out very poorly for them. I'm not going to go through that again. Drug binding can occur in two forms, where you're actually binding to the receptor that is going to produce an effect, and you're binding to something that is just going to be a distraction for your molecule. Cannabinoids binding to fat is a great example here of a depot binding. And if the drug is bound to the fat, it isn't going to produce that effect immediately, but it can also have a slower offset that is going to produce a positive drug test for weeks to come. Affinity is the concept of the attraction between a drug and the receptor, or its ability to bind. So LSD can have a high affinity for some receptors, like the 5-HT2A or T2C receptor, and a low affinity for others, like the 5-HT27 or the dopamine D5 receptor, which is all you're looking at this cable right here. The The 5-HT2A and 2C receptors are what's supposed to be responsible for serotonin's visual hallucinations. So, this basically, a low Ki on this chart means that it binds tightly or has a high affinity for that receptor. And this is based off of this idea, the vision of the ligand, the chemical or the receptor itself, functioning as a basically key for a lock. Drug competition is an important concept to think of for many reasons, including your own health. If two drugs that are metabolized by the same enzyme are co-administered, they can be active for longer and in higher concentrations. So you combine a muscle relaxant with alcohol. In addition to those having similar effects in the brain, there's also a pharmacokinetic problem there because both of those might be metabolized by cytochrome P450, and alcohol, for it to be effective in you, you actually have to saturate a good percentage of your cytochrome P450 enzymes in your liver. And then when you do that, that enzyme also isn't going to be breaking down the muscle relaxant, so that's going to have a much more pronounced effect in you. Other things to think about are enzyme inhibition, the reduction in metabolizing enzyme associated with a particular drug. MAO inhibitors are something we'll talk about a lot in this unit. MAO inhibitors are an older antidepressant that basically are being phased out in favor of SSRIs only because SSRIs are safer, not more effective. But MAO inhibitors break down or prevent the enzymatic breakdown of noradrenaline and dopamine and serotonin, leading to these neurotransmitters being higher in the brain. But they also can interact with things like wine and cheese that produce a high amount of amino acids that need to be broken down by enzymes that also would be breaking down the monoamine, and they're now inhibited. And that can lead to cardiac hypertension and death. It's also important to note that there are genetic polymorphisms that can influence how a drug is metabolized. Approximately 50% of Asian groups have reduced capacity to metabolize acetaldehyde and intermediary breakdown of alcohol. Now let's talk about inactivation and excretion. Drugs don't stay in the body forever. Many are deactivated by enzymes and excreted by the kidneys. When they do so, they can be excreted as active metabolites that would then have an effect on the body, a continued effect if they're reabsorbed into the blood. Alternatively, you can get an inactive metabolite that isn't going to produce continued effects. So when we talk about drug effects, I'm going to be talking about a lot of dose response curves, which I need you to be able to recognize on a quiz and an exam. So what you're seeing at a dose response curve on the y-axis is an effect being plotted out with dose on the x-axis. So here you can see what is a very stereotypical sigmoidal dose response curve. The effect of a drug on you goes on a specific effect is going to increase with dose until it plateaus and you do not get any more additional benefit at this one effect. Potency is generally measured across the x-axis, and effectiveness is generally measured across the y-axis. So potency is the difference in the effective dose 50 of two drugs. So ED50 means the dose that would be effective in 50% of the population, and by effective I mean 50% effective. Effectiveness would mean that there's a difference in the maximal effect that the drugs will produce at any time. So for example, aspirin will never be as effective as morphine, And whereas LSD would be much more potent than lysergic acid amide at producing hallucinatory effects. So what does this look graphically? So drug A versus B versus C, you can see three different examples of potency, but all have the same efficacy. All are producing the same maximal effectiveness because they all reach the same level on the y-axis. But drug A is much more potent than drug C. Here, drug A is much more efficacious than drug B. Drug A is also more potent than drug B. Here, I would say that hydromorphine, morphine, and codeine all have the same maximal effectiveness. Aspirin has a lesser maximal effectiveness. Aspirin also has lower potency than any drug. Hydromorphine has higher potency than any drug. So which drug is the most potent? Which drug is the least effective? Which drug is more potent than codeine? These are the sorts of questions that will be on the exam. So again, yeah, and potency would be changes along the x-axis, efficacy changes on the y-axis. ED50 is the dose that produces the desired effect in 50% of the subjects. The dose that produces a 50% effect, really, more than a desired effect. 50% maximal desired effect in 50% of the population. LD50 is the dose that produces a lethal effect or a toxic effect in 50% of subjects. Therapeutic index is the ratio of the LD50 to the ED50. So the higher the therapeutic index, the safer your drug. Efficacy might be ED50. That would be the medium effective dose. Lethality could be thought of as LD50 or the median lethal dose. So you would want to stay between the ED50 and the LD50 and really pretty far away from that LD50. So the therapeutic index would be the LD50 divided by the ED50. So here you can see the therapeutic index or the margin of safety in between two curves right at around where the ED50 and the LD50 would intersect. The LD50 is represented by the blue curve, the dose response curve for the depressive effect of morphine on respiration, whereas the yellow line would be the dose response curve for the analgesic effect of morphine. This is a figure of two different dose response curves. Here we see the effect on hypnosis and death of a particular drug. You can see how this would be calculated. The LD50 would have a value of 400 because that would be at the 50% point. And then the ED50 would be from, you draw that down and see that that has a value of around 100. So your therapeutic index would be 4. And then you could determine if another drug was safer or more dangerous relative to this drug by doing a similar observation. So in general, you're going to want a wider therapeutic index, which would mean that your drug is safer. Here are some common drugs of abuse and common medicinal drugs on the, basically taking therapeutic index into account. Cannabis, which again, basically can't kill you from respiratory suppression, has a very wide therapeutic index. And, heroin has one of the narrower therapeutic indexes. Fentanyl would be significantly lower. So this is just food for thought, how these things relate to drug scheduling. And of course, danger is only one part of drug scheduling, but, I would say that our current drug schedules don't necessarily represent, safety. Here is just a very similar graph, showing similar effects, but Many of these drugs, I would say, could be considered to be safer than alcohol, which is a drug that basically we build shrines for in every town. I mean, if you go into, like, that's just what I see when I see a bar. It just looks like a big shrine to me. Very common in drug abuse. Opioid users, even cannabis users, tend to build their little shrines of drug abuse. So I mean, here's a sort of question I might ask on the exam, like which drug is the safest for human use? And now I wanted to briefly go into the repeats of repeated administration and focus on the concepts of sensitization and tolerance. Tolerance would mean decreased effectiveness of a drug that is administered repeatedly. So you get tolerance to an effect, not tolerance to a drug. And this is where I think it's important to think of a drug as producing many effects. So for example, I can become tolerant to the analgesic or pain relieving effects of opium without becoming tolerant to the respiratory suppressing effects of opium. You see why that would matter, right? Okay. So in addition, you can develop sensitization or increased effectiveness to a drug that is administered repeatedly. You can also suffer withdrawal symptoms or appearance of symptoms opposite to those produced by the drug when the drug is administered repeatedly and then suddenly no longer taken. For desensitization, you see decreased response to the same dose with repeated or constant exposure. The more drug is needed to achieve the same effect over time, and generally you would see what is this as a rightward shift of the dose response curve. This can occur even within an acute or daily or short-term setting and can occur across drugs. I have personally shown that you can get cross tolerance between cannabinoids and opioids, which is, I would say, a point of concern. But anyway, this is commonly caused by compensatory mechanisms that oppose the effects of the drug. Sensitization is an increased response to the same dose with repeated, intermittent exposure. And this is typically thought of as a leftward shift in the dose response curve. This is commonly associated with intermittent use of stimulants. So cocaine or amphetamine might hit you harder if you take like a month off between your binges, for example. And can also develop across drugs. You can see this jump between amphetamine and methamphetamine and cocaine, for example. And it's also important to know that you can develop sensitization to some effects and tolerance to the others. Placebo effects is also something to be aware of. An inert substance that is given to an organism in lieu of a physiologically active drug is a placebo. This is used experimentally to control for effects of more administration of a drug. Don't say placebos have no effect. They certainly have specific physiological effects. These can occur. It's basically tricking the body into producing a physiological effect like a drug. Antidepressants have been said to, some have argued that antidepressants are actually functioning as placebos in up to 50% of people. Vitamin C, I don't think produces any effect in reducing the cold. Maybe that's a 100% placebo effect. You can also get placebo drunk, quite literally, which was discussed or parodied in Freaks and Geeks. But I feel like this has been you see this in kids. They want to act like they think they are intoxicated, and then take something and act like it, but really we're actually just drinking water or something. There's also the nocebo effect. Well, this can be harm resulting from the mere expectation of harm. Voodoo, this can also occur from overdose on placebos. Basically, the worsening of symptoms can be the consequence of exposure to the placebo. but the symptoms, yeah. So who was one of the first people to discover the placebo effect? This would be Ben Franklin. I'm not going to go off into the story on this one because we're already short on time, but a fun one to look up. Also look up Dr. Franz Mesmer and the concept of animal magnetism. Invisible magnetic fluid. He believed that there was an showed that there he believed there was an invisible magnetic fluid, and there was a natural energetic transference that occurred between all animated and inanimate objects. Ben Franklin commissioned a magnetized approach, but told people it wasn't magnetized, and in other cases told people a tree was magnetized when it was not, and demonstrated that people only experienced the fainting spells when they believed that the trees that had been magnetized as part of Franz Mesmer's magnetism sort of gimmick. So anyway, that is, I guess, the story of how Benjamin Franklin, showed the concept of placebos, all to sort of discredit, if you will, this sort of idea of animal magnetism. So definitely be sure to look that up further, though, and I hope you enjoy what will be a lot of information on pharmacokinetics and pharmacodynamics as we move forward.